Hi, everybody, and welcome to week 4 of the ARC Michigan's Disability Public Policy webinar series. Before we get started, I have a few housekeeping items to go over. If you're not familiar with GoToWebinar, you're going to want to locate the orange arrow on the right-hand corner of your screen. This shows and hides your GoToWebinar control panel. If you've joined via the app on your phone, the control panel is at the top or bottom of your screen. If you have an issue with your audio, go into the control panel, open the audio tab, and do a sound check for your mic and speakers. Participants are muted for this presentation, but you can type questions into the GoToWebinar question window that's in the control panel. If you need tech support, you can also request that help there. Also in the GoToWebinar control panel, there's a handouts tab, and that's where you'll find a copy of today's presentation. If you were to lose your GoToWebinar screen, look for the blue flower icon in your taskbar, unless you're on an Apple device, and then you're looking for an orange flower. So now I will hand things over to Sherry Boyd, CEO and Executive Director of the ARC Michigan. Good morning, Sherry.
Good morning, Emily. Thank you for everybody for joining us this morning. We are excited to finish up our public policy webinar with Nicole Jorwic, who is the Chief of Advocacy and Campaigns at Caring Across Generations. If you guys remember her, she's been doing the federal updates for us for a number of years, and she had previously worked at the ARC of the United States. With that, I'm going to turn it over to Nicole so she can talk a little bit about the new organization she's working with and to give us some more, I'm sure, insightful information. Thank you, Nicole.
Thanks so much, Sherry. It's a pleasure to be back. I very much miss the ARC and always glad to be back with the Michigan folks, and very excited to be able to share that in my new role and with our new organization. We're doing a lot of work in Michigan to expand long-term services and supports, and are proud to partner with the ARC Michigan and several other Michigan-based organizations as we kind of restart that work. But glad to be here as always. And I'm going to talk a little bit about obviously what's going on in Congress. I did check in with some of my friends at the ARC to make sure that I wasn't missing any other issue areas that I no longer work on, because I'm really pretty much primarily focused on home and community-based services, which I'm sure will not be a surprise for folks who have heard me speak in the past. But I'm also going to kind of talk through how we got to the moment that we're in terms of hopefully being on the precipice of additional federal funding for a lot of things, including home and community-based services, but also how we've really been successful at the federal level, at the national level, of breaking down silos between issue areas to kind of build power around things like the need for home and community-based care, and working together with groups that sometimes can be complicated, but has also proven to be incredibly important. So when I talk about care policies, care can be a complicated word. It's something that we've been doing a lot of work around, generally because we want to make sure that care is seen as a kind of a two-way word. It's not caretaking, it's caregiving, and that also means that, it means that we're also respectful and honor the experiences of those who need care and receive care, as well as those who provide it. And that includes family caregivers, and also obviously paid workers like direct care workers that we focus on a lot. For Caring Across Generations, the organization was created a little more than 10 years ago to be a place where family caregivers, paid caregivers, and those who receive care can come together to work on policy change and also narrative change. So really getting the general public more understanding of issues surrounding care. For us, when we talk about the pillars of care, what we're talking about primarily, home and community-based services. That's part of why I went over, really expanding access to those services for older adults and people with disabilities, but also childcare and paid leave policies that support folks throughout the lifespan and also those who need to provide care. COVID, obviously, I've presented a couple times during COVID. That's really weird and to think about that this would be my third presentation on over GoToMeeting with the ARC Michigan. But it's really also where we tried to build power. And actually, I started working with Caring Across Generations when I was still at the ARC through a coalition called Care Can't Wait that Caring Across Generations leads. And Care Can't Wait was the idea that kind of operationalized the concept that what we're trying to do is between those issue areas, childcare, home and community-based services, and paid leave, starting to speak each other's language, break down the silos between even issue areas. Within home and community-based services, there's obviously there can be a great deal of difference between what aging advocates might be fighting for, or what disability advocates or what labor advocates might be fighting for. But actually there's more similarities than differences, and we've kind of historically done a disservice by not kind of working more together and finding those areas of similarity and fighting to change those pieces. And so COVID really gave us the horrible thing that happened with COVID, gave us the opportunity to sit down and kind of break out of that mentality of scarcity to figure out how we can build power. At Caring Across, we see care as a shared need and collective issue. It's something that for so long individuals and families have been thought of it, have been told by society and have thought of it for cultural reasons or other reasons as an individual kind of, I don't like the term burden as a family caregiver, but instead of something that we need to have societal solutions for and political solutions for and policy solutions for. So the pandemic really revealed a lot of the assumptions about where care should take place, and also the inequity of continuing to go forward with a system that has never been inclusive and has never had workers that are paid a family sustaining wage, et cetera. And so we know that we need to shift the narrative. That's one core component of how Caring Across operates, as well as through policy change. We know, and this is actually a preview of a slide for a session that we have going on later today, that really highlights the cost savings of because of the cost of not having access to these services. So the average annual out-of-pocket costs for family caregivers is over $7,000 a year, and for Black and Hispanic families, they report greater financial strain of 34% and 47% of income, respectively, having to go to support family members who need it. And so again, it's really an equity issue, and it's not something that doesn't have real costs. The fact that we don't have a care infrastructure, that's kind of how we talk about care infrastructure, is how we talk about a system that should exist, which is a system that has all the workers who need it, who we need in order to provide services, that doesn't leave the 850,000 people currently on waiting lists. Without it, there's a real cost to that. That's just the out-of-pocket cost. That also doesn't factor in, we know when I was still at the ARC, we worked with Harvard University on a study that showed the business case for supporting family caregivers that had included data of how many family caregivers have given up opportunities for promotion or extra work responsibilities because of those caregiving needs that aren't being met by a system that doesn't have the capacity that it needs. This is just some more data about from the National Alliance for Caregiving and AARP about kind of, again, the financial impact. And that's because we're focusing on that issue right now at the Hill because as everyone knows, inflation and the cost of living has gone up. And so really highlighting how this is something that helps families when we invest in it is part of how we're trying to bolster our argument for budget reconciliation, which I'm going to get into in a little bit. At Caring Across, we see the investment in the care infrastructure also as a justice issue. Most of the direct care workforce, whether it's direct support professionals or home care workers, are women, and primarily women of color. And these are wages that at a national level are less than $12 per hour. And so we need to make these jobs good jobs with career paths and also with a family sustaining wage. And it really, aging and disability justice requires that we're also addressing the workforce issues. I know that during my 7 years at the ARC, that was the #1 thing I heard about from folks. And so we needed to utilize this moment where we really are seeking big investments to fundamentally change how we're paying the workforce that provides these services that really make all other work possible. So the past year, Build Back Better is not a term we use anymore because that is the bill that originally started as a proposal in 2021 that was originally at $400 billion for home and community-based services. And it also had a lot of other big proposals, including the first federal paid leave program, huge investments in childcare that has continued to get whittled down. The House did pass Build Back Better in December of 2021. That did include $150 billion for home and community-based services. But because what's happening in the Senate, the number is going to come way down. And so now we're really focused on getting as much as we can. But it's, the fact that we're still in is really a testament to the coalition that's been coming together. Home and community-based services has also gotten a nod, not just with that inclusion in the Build Back Better agenda, but also, and actually it just, the actual bill to operationalize the budget just came out and included not the full 500 million that was included in the Biden budget, but it included 451 million to home and community-based services. And just for a point of clarification, because 500 million is a lot, or 451 million is a lot, but it's obviously not comparative to the huge investment that we're seeking. And that's because when it comes to the budget, that's only for non-discretionary funding. And so Medicaid, the primary funder, and I'm of course going to go a little bit into the intricacies of Medicaid because I can't put a PowerPoint without including that, but that's mandatory spending. So that's in a different part of the budget. This 451 million is specifically to support access to home and community-based services through supporting the Administration for Community Living, which is the part of the federal agency, Health and Human Services Agency, that oversees community living opportunities for people with disabilities and aging adults. And so it really is positive that Congress is, while they didn't put it to the full 500 that was requested in the budget, it is a $51 million increase from what was passed in the last budget. So again, these are all nods to the issue while negotiations continue. So this should actually stay the next couple of weeks because the window of opportunity is narrowing to make the needed investments in the care infrastructure, but there is still a moment that we're looking for right now where things are for folks that aren't glued to some of the 24-hour news stations, is that we have been waiting for the bipartisan gun safety legislation that just passed the Senate overnight. Because that was obviously taking up a lot of the conversation, a lot of the staffers' work, et cetera. So the fact that that has moved means the Senate now can refocus on budget reconciliation. And budget reconciliation, if it sounds familiar, it should. Not only is it how the short-term funding, the American Rescue Plan Act funding, the $12.7 billion for home and community-based services that passed in March of 2021, that was done through budget reconciliation. Also in 2017, when we were facing major cuts, that was also through budget reconciliation. And it might sound confusing, budget reconciliation and health and human services funding or childcare funding. The only reason it's called budget reconciliation is because there's very strict rules on what can and can't be included, including the fact that it has to be mandatory spending like Medicaid, but also that it only requires a simple majority to pass the Senate. Right now, the majority of legislation, like the bipartisan gun safety legislation, requires 60 votes. Budget reconciliation only requires 50, and because of the current political makeup of the Senate, it's an even split. And so what we would anticipate when the package does come together is that Vice President Harris, just like she was with the American Rescue Plan Act vote, will be the tie-breaking vote. That's kind of just a little more procedural, but since I know it can get wonky, I just always try to do a little bit of an explanation on that. And while we are still seeking $150 billion for Medicaid home and community-based services, we will hope that we can get close to that number. The number could come down, but the really positive thing is that we are still part of the conversation. Right now, we're talking about a package that is going to include things like climate and energy and changes to prescription drug pricing, and also some broader deficit reduction. All of that costs some money and saves some money. And so what we're waiting to see and where the process is right now is the Senate is negotiating, and they're also meeting with the Congressional Budget Office to see how much these pieces will cost and how much they will save. And once we kind of know the savings, we'll know how much funding we can realistically seek out for home and community-based services. We're hoping, again, to keep it very close to that $150 billion. And that $150 billion right now is structured in a way that it would support both access to services, so increasing access, pulling people off of waiting lists, increasing hours, that sort of thing, and also address the direct care workforce issue, making sure that we're creating but training opportunities and most importantly, raising wages. So the policy, what's in the policy might change if the number goes down. We are always talking with Senate offices about that. We really know that the investment needs to be in the workforce in order to build the infrastructure, the human infrastructure that we need to pull more people off of the waiting list. The current system really can't function without more supports. And also we're focused at Caring Across also on insurance and Care Can't Wait to ensure that we can get some childcare investment. Unfortunately, paid leave has been off of the table since the end of last year, but we can circle back. So I can't, like I said, go in front of anything without talking about Medicaid, because I do think it's important as advocates that we understand the why behind why we need these investments. And the why is really because of how important Medicaid is to people with disabilities, to the workforce. It's also a complicated program, which makes raising wages and things like that more complicated. It's important for us to understand the history and the intricacies, so that when we're sharing our stories about why these things are important, we can say, and that's why we need to make these changes and these investments in Medicaid. Medicaid nationally, it is a traditional healthcare program, but also over 11 million people with disabilities rely on it for healthcare, but also for services and supports to live independently. So it's much more than a healthcare program. It is the main funder for what we call long-term services and supports, LTSS, including home and community-based services, or HCBS. So where the term HCBS is actually out of the Medicaid law. And the reason that it's really important for people with disabilities and disability justice advocates to really be focused on advocating for that, for more funding, is because while those groups can account for about half of the costs of Medicaid, they only make up about 21% of the beneficiaries, because again, the rest of it is for traditional healthcare in a much broader eligibility base. So it's really important that we're addressing how to invest in these issues as a constituency. As I said, this is a slide from Kaiser Family Foundation that really outlines the fact that Medicaid is the main funder, as well as private pay. Private insurance is a very small payer for long-term services and supports, and that's obviously mostly for older adults. And so again, it's why it's really important that we're looking at it. Medicaid is complicated because it's called different things in different states. Different states have different functionalities. I know in Michigan, there's a managed care system in place, a county-based managed care system, but fundamentally what it is that the federal government and states share actual costs of coverage. They agree in each state who's eligible and what services and supports are provided. There's the federal Medicaid law sets a floor for those services, but states can go above and beyond that and also have their own eligibility requirements. But on average, the federal government pays about 63% of every dollar going to Medicaid, but it varies by state from 50 to 75%. So while it is this there's a federal law that oversees the program, state funding goes into it, but a state government knows that for every dollar that they invest, that they're going to get that money back based on that percentage. Those percentages, or federal matching assistance percentage, or FMAP, you're going to hear that, or you probably might have already heard that, and that's because how different, like the American Rescue Plan Act fund provided additional funding for HCBS, was providing a bump or a plus up to that FMAP, or that federal share. And so if you were in a state that was at 63%, for 1 year, the American Rescue Plan Act bumped that up to 73%. So that's how more federal dollars flow into the system, and then states have to make sure that it gets spent on doing what the federal law said, which in that case, the American Rescue Plan Act was for expanding and enhancing access to, expanding and strengthening access to home and community-based services. So states submitted spending plans because obviously that's a pretty broad term. And then CMS is making sure that CMS, which is the Center for Medicare and Medicaid Services, the federal agency that oversees it, signs off to make sure the money is going where it's supposed to go. I want to pause because I just want to make sure there's no questions. I saw something jump up and I just want to make sure. Okay.
Not at this time.
Okay. So again, it is a state and federal partnership, but it's overseen by a federal law. And the federal law says what services under Medicaid are mandatory services, and that includes those traditional healthcare services. It includes prescription drugs. It also includes nursing home services and other institutional services. And because of that, it's guaranteed to states. And then Medicaid also has optional services. And so while they're not optional to the people who need them, the federal law has home and community-based services as an optional service. What that means is that states can cap or limit how many people have access to those services, and that operationally looks like waiting lists. Though it is important to note that even in states that don't have waiting lists, that doesn't mean that there are not people that are waiting, whether it's due to lack of staff or lack of capacity for certain types of services, or the amount of hours of services that they need. But generally, the fact that home and community-based services are in that category of optional services means that they're particularly at threat, which is what we saw in 2017. That would have been where any cuts to Medicaid would have been the first place that they came. And it's something that, and I'll talk a little bit kind of about future advocacy, but it's something that we're always looking at, because home and community-based services were only created 41 years ago in 1981 under the Katie Beckett waiver. Katie Beckett was a young girl with complex medical needs from Iowa who was stuck in a nursing home, and whose mother fought very hard to make sure that she had access to services in the home. And so that's when they started. And up until that point, you know, a lot more facility-based care was preferred. We're seeing that less and less so. I know Michigan has already made a lot of shifts and changes, but also with the pandemic, we've seen a bigger shift. And so we need to take advantage of that to keep moving towards making the federal law reflective of what people want, which is home and community-based care. What are home and community-based services? I know the majority of folks on this call know this and provide this, but it can be everything from help with cooking, assistance with self-care is really personal care, but it's also job coaching, community volunteering, day programs, other things that support people to have a meaningful day. So that's kind of a little overview of where we're at with home and community-based services. Our goal is, again, to get this major investment moving forward. But we're also, when we're talking about the care policies, we're also, like I said, talking about things like childcare. And so really the only federal program was also 1965 was a big year. That was Medicare and Medicaid. It was also when Head Start was created to provide supports for low-income families. But there haven't been major investments in decades. And just like, and this is again where it's been really helpful to be having these conversations across care issues, because just like direct care workers, child care providers, or child care workers are also making low wages. And so it's something that, and also that workforce is made up predominantly of women of color. And so combining our issues as we're advocating has been really helpful. I'm sure you all know, because it was something that I worked on well, Bethany and TJ worked on it, but that the ARC was involved in. You know, paid leave is something that has unique and important aspects that have to be included to address the specific needs of the disability community. There was some emergency paid leave through some of the COVID legislation. However, at the federal level, we still don't have a paid leave policy. There is the Family and Medical Leave Act, which does grant certain categories of folks 12 weeks of unpaid job protection, but we still don't have that job protection for folks, including people like me, who are siblings. I actually should have done a little bit more of an intro at the beginning. I just kind of assume everybody knows, but I do have a brother that has autism, and have definitely had to take different times to make sure that I could be there to support him. I'm also on the care team for my grandma who has Parkinson's. So those are the real things that folks need to do to care for their family members. So there have never been a national program. As I said, there was that emergency paid leave through COVID relief, but that all expired September 30th of last year. Also, just as I said, I checked in with folks from the ARC to make sure that I could be fully up to date on where different pieces are that I don't necessarily cover every day. Something that just happened in the last week is that Able Age is now part of the Enhancing American Retirement Now, or EARN Act. And that, for folks that aren't familiar with Able Age, Able are the accounts. That bill was passed almost 10 years ago, in 2014, which allows people with disabilities to save without putting at risk their benefits, so their eligibility for things like Social Security and Medicaid. When the bill was passed, because of negotiations, just like are going on right now with budget reconciliation, and because of the cost, the disabling event had to have occurred before the age of 26. So that obviously leaves some people out, doesn't necessarily leave people out with IDD, but some. And so now this bill, when it passes, will raise that to the age of 46. The goal is to ultimately get it up to the retirement age, but sometimes incremental is the way that things have to move. Stop the shock. For folks who aren't familiar, there's one place in Massachusetts, the Judge Rottenberg Center, that uses electric shock devices. It's horrifying to talk about, but uses electric shock devices on people with disabilities. It has been an issue that the ARC and the ARC of Massachusetts has been involved in. for over 40 years with legal opposition, and we worked together to get a 200,000 person petition delivered to the FDA to outlaw those devices. It's been complicated. However, very excited to report it's an issue I covered during my time at the ARC, but sometimes things happen after you leave. And so actually it was just included a ban on these devices in the FDA user fee reauthorization bill that just passed the House and is expected to pass the Senate. So 40 years of advocacy is going to, hopefully, knocking on wood, going to come to fruition and end the torturous device use. I could go on about that, but I won't. It's been a really difficult but important issue to work on in the last 7 years. Social Security, this is exciting because like the majority of legislation that has helped people with disabilities, this is a bipartisan effort. It's a bipartisan effort from Senators Brown and Portman from Ohio. And it's the Savings Penalty Elimination Act. I know that the ARC just sent out, because I'm still on the list, a big action alert about this yesterday, if folks haven't gotten it. But, you know, just like many things haven't been changed since the 80s when it comes to people with disabilities, currently individuals who are receiving SSI or social supplemental income are limited to $2,000 in assets, and for married couples it's $3,000. This bill would amend those caps again, which haven't been updated since 1989, up to $10,000 for individuals and $20,000 respectively. Another really important component of this is that would really fundamentally eliminate what's called the marriage penalty, because it would simply double the asset limit. And if folks aren't familiar, the marriage penalty is the fact that for people with disabilities or others who rely on SSI, if you get married, obviously only being able to have an extra $1,000 is not enough. And so that's something that has been on the ARC's public policy agenda for since about 1989. So that's another really exciting thing that we're hoping can get included. It's not going to get included in budget reconciliation, but we do expect that there will be additional legislation after the elections in November. And so kind of the what's next. I obviously have been talking about budget reconciliation. That's all hopefully going to come together. It really has to come together by August recess, which really this year actually starts in the second week of August because of the Senate calendar. And it really has to, mostly for political reasons. It has to come together or it won't come together is everything that we're hearing. And so that will happen. Then they will come back in September. There's some work that Congress will have to do, but it's unlikely that any major legislative packages are going to pass in those 2 months between them coming back from August break and the election in early November. But what there will be is what they call a lame duck session, which is when, because obviously not everyone a lot of folks are retiring, others will lose their races. And so that's when Congress comes back. And then before the new Congress, the 118th Congress is sworn in January. Depending on what happens with budget reconciliation, there could be some attempts to get another bite at the apple on some of those policy areas. But, you know, we just kind of never know. And so that's where the calendar is. And then once we get into the 118th Congress, we don't know what that's going to look like yet. We will know that in November. But we have major goals for addressing some of the systemic problems that have really led us to where we are in terms of the lack of care infrastructure in this country. Folks have probably heard me talk about this bill, but the HCBS Access Act came out in March as a discussion draft in March of last year. It would address longstanding issues around access to home and community-based services. It also would fundamentally address what we call the institutional bias in Medicaid, and that is the fact that facility-based services are mandatory while home and community-based services are optional. And so it would make home and community-based services mandatory under the law. It wouldn't change any other, it wouldn't, take away anything else. It would just add home and community-based services into that pot. It would also, though, provide funding to build capacity and eliminate waiting lists. It would provide 100% federal funding for a series of years in order to build the capacity that the system needs. You can't, like I said, just pull almost 1 million people into the current system. Also, there will be that some of that 100% federal dollars will support increasing funding to raise direct support professional wages. And while it won't technically make Medicaid portable, meaning being able to leave from one state to another, right now, my brother's in Illinois. If he wanted to come live with me, he could not. But what it would do is it creates a new federal floor for services. And so if somebody is moving from state X to state Y, they would know that that those same services would be available and that there wouldn't be a waiting list. So it really does address that portability issue in that way. So this is major. It obviously will also be very expensive. It will be a little less expensive because of hopefully the funding that we get coming up here. But that is going to be a top priority for Caring Across Generations. I know for obviously the ARC as the new Congress starts. And in order to get that done, we need to make sure, again, that we're not just talking to and with people who already understand the issues, but that we're ensuring that there's an understanding that care issues are nonpartisan. We're probably looking at a very different Congress. And we need to be ensuring that we can show that in every district and in every state, people have these needs and need the support. We have to get general public buy-in on our issues. We learned in 2017 that even people who were receiving the services didn't know that they were Medicaid or didn't know that a waiver meant that it was funded by Medicaid and those sort of things. So not only do we have to do more education within our own constituencies, but we also have to make sure that there's an understanding that everybody is, if they're lucky enough to age, going to need some sort of support in order to address these issues. We also need to be continuing to engage with presidential campaigns and all other campaigns. That's a big component of what Caring Across does to our partner, Care in Action, to support political candidates who are running on some of these issues. The next phase of advocacy is really going to be around HCBS Access Act, advancing paid leave and childcare. It's also going to be around creating access to long-term services and supports outside of the Medicaid program. We know that obviously we need to ensure the solvency and availability of Medicaid services, but there are also some people that are left out of Medicaid, maybe because of their disability diagnosis or other reasons, like some people with autism might not qualify for Medicaid, but still need those long-term services and supports to work and access the community. And so folks might recall that the Affordable Care Act, when it passed, actually did have a non-entitlement, so non-Medicaid long-term services and supports, or LTSS benefit, that was later repealed. That would have been a cash benefit to individuals who needed supports to help them pay for some of those personal care services and that sort of thing. That bill was repealed, but there's a lot of interest in looking at that in the House committee that oversees Medicaid, Energy and Commerce. The head of that committee, Representative Pallone from New Jersey, has a bill that would do something like that through Medicare for both people with disabilities and older adults. So there's always going to be additional advocacy, because I do think that we're in a moment in time that's different than any time that I've been doing federal advocacy work, when you do have more people paying attention because of the pandemic. I keep kind of saying that the genie's been let out of the bottle, and now we have to make sure that we don't let people forget that these are big systemic problems that we need to fix. And I do actually think that there's a real interest in it. And again, a bipartisan interest, and that's something that we have to continue to build on and fight for in the next Congress. That wraps me up on my slides. I wanted to leave plenty of time for questions. So I will, if there are any, or else open it up to folks to ask questions now.
Thank you, Nicole. If anybody would like to type questions, you can find that tab in the GoToWebinar control panel. So I have a couple comments to start with, and then we do already have a few questions, Nicole. So
Okay.
First comment is, thank you for the history on the Katie Beckett waiver. 41 years was not that long ago.
Yeah, yeah. And her mother just recently passed away, which was really sad. And I was lucky to get to know her recently, actually, because she got involved during 2017. And being a family member, kind of, and my brother receives home and community-based services. It was really personally fulfilling to meet her, but it is important to realize it wasn't that long ago that folks' only choice would have been a facility.
Next question is more of a comment, but are those at the federal level aware of all of the waiting lists in every state? And that can't be resolved without meeting this funding request.
I do think that there's more awareness than there ever has been. I think that awareness needs to also come with the political will to spend the dollars that need to be spent to fix the problem. And again, we're talking about 41 years where this has never been invested in the way that it should be. Even in states that have done great work, like in Michigan, for people with disabilities and expanding community options, it does require that federal investment because states are only going to be able to do things on the fringes. That wasn't always true, but that's certainly true now. You can't just, right now there's been a kind of a two-tiered system built when you have the federal law saying these set of services are mandatory. Well, then the state doesn't really have the choice. They have to keep funding them. And then you can, at the same time, when state human service budgets have been going down for decades, to expect that they're going to invest all these state dollars without knowing that there's federal support coming. So I think that there is an understanding, but it's why we need to continue to advocate that and really show pressure, and also political pressure, because again, these investments are going to cost hundreds of billions of dollars, not just what we need right now, but to get to HAA and other things.
Thank you. That flows right into my next question. Can you say the name of your organization again? And we'll drop the link to it in the chat. Is there a newsletter, some way to stay up to date? And I'll also post in the chat the link to the ARC Michigan's newsletter and advocacy alerts.
Yeah, so the organization that I now work with is called Caring Across Generations. I'm sure there's a way to join us. I should know that off the top of my head. And I'm also a really big fan of the ARC, of the United States Action Center, and that's just the arc.org/action. But yeah, the organization the new organization that I work with still partners, obviously, with the ARC, and works really closely to ensure that we're inclusive of all of the disability components, which is obviously important to me.
The link that's in the chat actually will allow you to join for folks who are on the line.
Thanks, Sherry. And just so you know, joining is just like a list. It's not, there's no cost or membership or anything.
Thank you for that clarification.
Mm-hmm.
Can you provide a status regarding the Work Without Worry bill, as well as other bills that are in the House and Senate that would like to establish a standard occupational classification for direct support professionals?
Yeah, so the Work Without Worry bill, some of the components of that were incorporated into the Brown-Portman bill that I talked about for Social Security. It's unlikely that that's going to move this year, but it definitely has some good bipartisan support and political will. So hopefully we can get to that next Congress. Excuse me. The bill, the SOC bill, the Standard Operating Code, that's a bill that's close to my heart. And in my free time, I'm a member of the board of directors for the National Alliance for Direct Support Professionals. And so that's a bill that obviously NADSP has been very involved in pushing. And for folks that don't know, one of the many reasons that the workforce wages are low is that for direct support professionals and that support people with IDD, there is no standard occupational code within the Department of Labor. Why that matters is around data. So sometimes something that we've really been working hard on is using inclusive terms. So that's why you might have heard me say direct care worker a lot. And we started doing that because traditionally things like home care and home care worker are the only things talked about, and those are important jobs and important work, but it's not the inclusive term. The inclusive term is home and community-based services. The inclusive term is not home care worker, it's direct care worker. But the reason that is because when you see big reports like from PHI, they're going to focus on home care work because that's the only data that the Department of Labor is collecting, because there is a standard operating code. So states don't have to, states and employers don't have to report on wages and other things like that. And so we have ballparks and estimates of things like national wages for direct support professionals, but without that standard operating code, we can't collect that data, and therefore, and really can't address the underlying issues that have led to the low wages, because we know DSPs probably make on average a little less than home care workers, despite the fact that they're doing a wide variety of things, supporting folks with everything from personal care to socialization to maybe working. And so that bill, there is a chance, because there's not a major cost to it, that we could try. I mean, I'm always talking about it when I'm lobbying on the Hill, that we could maybe get it included in budget reconciliation. But I do think because of, you have Anchor is the kind of provider association in DC working with NADSP. And so hopefully we can see that happen, because the Department of Labor has made it clear that they're not planning to do it on their own, because they could, until they reach their like 6-year review process, which is still, I believe, 3 or 4 years away. And so I do think that we have a chance there, but it's going to take additional advocacy, which we're figuring out how to do.
Expanding on that question, how would that legislation support the family caregiver?
Well, I mean, it would support family caregivers who might be acting as direct support professionals, but that SOC bill wouldn't necessarily have an impact on family caregivers. There's obviously a lot of other, and including, there are components of the HCBS Access Act that directly also seeks to expand funding for family caregivers, always seeking to expand funding for respite and things like that. But nothing in that bill directly would go to family caregivers, unless they're DSPs.
Thank you. Is the HCBS Access Act still in draft form? And do you expect it to be officially introduced during this congressional session or next?
Well, we were hoping for it to be introduced officially this session. However, because you have the main drafters, and I should have mentioned, in the Senate, that's Senators Hassan, Brown, and Casey, and in the House, it's Michigan's own Representative Dingell, who we, of course, love and work with all the time. But because they've been involved in trying to get the HCBS funding in the reconciliation package, understandably, we're glad that's where their attention is. Their staff has definitely started having meetings and reviewing all the feedback that they got. It's possible that we'll see introduction during November, December, but most certainly during early next Congress official introduction. So good question, because I should have clarified that it is still in discussion draft form, but that's just because they want to include the feedback that they got before official introduction, and they're definitely on track for that.
Thank you for that clarification, Nicole. Our last question is about the federally mandated electronic visit verification. And is there any movement nationally to change or eliminate that requirement? And if no, what does that look like in other states?
Sure. So electronic visit verification, or EVV, was first required under the Cures Act, and they are working on a Cures 2.0, and there are a lot of advocates led by Nicole, the National Council on Independent Living, to make the fixes that we've been trying to make since Cures passed in Cures 2.0. For folks that might not be familiar, there are problematic components of electronic visit verification, including some of the systems that have been created don't allow for people to do things like leave their homes, which is a really important part of community integration. Also, there's bio tracking components. There's also geo tracking components, and what people do with the data. There's a lot of concerns around that, but the reality is that the way that the law was written, I haven't worked on EUV for a minute, so I'm like going back into my file on my brain. So excuse me for a second, but the bill required that states implement that, or else they would get a ding or a decrease in their FMAP, that federal matching assistance percentage. So states did it, even if there were advocates on the ground understandably concerned. And so in those systems that states are using have some of those components. And so it's going to take a lot of work. Hopefully at the federal level, we can get those fixes included in Cures 2.0. But also it's going to require going to the states and saying, you need to look at the systems you're using, which is, a lot of them have signed contracts, and that can get complicated. But there is action. I just got invited to a meeting around advocacy for Cures 2.0. So it's definitely happening. And what it looks like in other states really varies. But I can't say that I've heard anyone identify for me a state that's doing it really well. If it is in Michigan, let me know. But.
Thank you, Nicole. That is it for our questions today. Thank you for being here, and I'll invite Sherry back in.
Hey, everybody, thank you so much for the updates, Nicole. We always enjoy hearing from you. I want to thank Nicole for joining us today in our final public policy webinar. And I want to thank all of the attendees we've had this month. And we are not sure if we will try to do hybrid next year or where we will be at, but this virtual world has kind of given us the opportunity to get to more people for sure. We have our attendance increased vastly from in-person conference. So anyway, everybody have a good weekend, and we will talk to you soon. Thank you, Nicole.
Thank you.
Bye-bye.